Good morning, good afternoon, good evening. Welcome. We're so happy to have you here today. We're just going to give it half a minute for everyone to get on and into the webinar. Thank you. Great. Greetings and welcome to our virtual workshop where we will be discussing and learning about real-world experiences applying an adolescent and gender-responsive health systems approach. We are building on the energy and excitement created last week during the Global Forum for Adolescents and the calls during that forum to ensure health systems meet the needs and rights of adolescents and that adolescents are part and parcel of advancing universal health coverage. My name is Callie Simon, and I'm the Adolescent Health Lead for Momentum Country and Global Leadership. We are so thrilled to have you join us. Video and audio permissions are off for attendees, but the chat is open. So we encourage you to introduce yourselves in the chat. And as we go along, you can type questions and comments in the chat box. When we get to the designated Q&A periods, you can also raise your hands and we'll call on you to unmute and ask questions. The workshop today will be recorded and the recording and presentations will be made available after to those who attend the meeting and to those who have registered. Our workshop today will focus on two overall objectives, which you can see on the screen. We aim to introduce the overall adolescent and gender responsive health systems approach and a tool that can be used to help make the approach more practical and doable. And we will learn firsthand from experiences in El Salvador, Kenya, Sierra Leone, and Zambia to increase our understanding of how to apply the tool and use the findings to strengthen the responsiveness of the health system. You can see on the next slide our agenda for the session. We have an action-packed 2 hours. We really hope you'll stay on for the breakout activities in small groups in the second half of our meeting today. We really look forward to discussing and learning with you and from you and your experiences. Without further ado, it's my pleasure to introduce our first speaker, who is Corey Warnell, the Youth and Reproductive Health Advisor in USAID's Bureau of Global Health, Office of Population and Reproductive Health. Corey is a key partner to us on advancing adolescent and gender responsive health systems and will offer some opening remarks. Thank you, Corey, and over to you.
Thank you so much, Callie, both for leading the way to bring us together for this exciting workshop that will help build dialogues between young people and decision makers in the health systems meant to serve everyone, including young people, and for that wonderful introduction. Also, thank you to Momentum Country and Global Leadership Project for your commitment to increasing the capacity of young people, increasing communities' abilities to demand the healthcare they deserve, and increasing the voices of youth so they may grow and contribute to the betterment of their communities. Greetings around the world to all who have taken the time to be with us today. We are so happy to have you here. I'd like to take a few moments to help situate today's discussion within the priorities of USAID, including our youth policy, as well as how this tool responds to the global conversation around adolescent and youth inclusion. In 2012, USAID became the first donor of its size to release a youth and development policy, solidifying its commitment to and focus on adolescents and young adults. However, the need to invest in young people to help solve our world's pressing issues is even more apparent now than it was 11 years ago. As such, last year, youth advisors from across the agency updated this policy, making it more robust by putting in a decade's worth of learning and growth into the next generation of USAID programming. The updated Youth and Development Policy highlights a clear vision and goal, along with 3 main objectives that focus on improved access, participation, and systems change. Because of their relevance to today's conversation, I would like to take a brief look at these three objectives. Access is where youth are better able to access high-quality information, safe services, and livelihood opportunities, and build the skills they need to lead healthy, productive, and engaged lives. Youth-responsive health services are equitable, accessible, acceptable, appropriate, and effective. Participation means youth have the right to fully participate in decision-making as key partners to contribute to individual, household, community, and national well-being. In the health sector, this means looking for the roles youth play now and those they can play when given room to, how they are supported by those around them, how they are networked with one another and with systems, and how their input is informing programs and services. And systems, wherein youth have a stronger collective voice in and are better served by local and national systems through more coordinated and effective services, practices, and policies that embody the principles of positive youth development. This is where the subject of today's workshop, the Adolescent and Gender Responsive Health Systems Analysis and Planning Tool, brings the USAID Youth and Development Policy to life. While we understand the intrinsic intersection of youth and gender, we will focus on the adolescent piece today, or I will, at least. I want to highlight that USAID is not the only global actor to take a systems approach for increasing positive health outcomes. Co-sponsors USAID, FP 2030, International Planned Parenthood Federation, the UN Population Fund, or UNFPA, the Bill and Melinda Gates Foundation, and the World Health Organization support the development and updates of the family planning high impact practices, a number of which are written specifically to improve the lives of adolescents and young people. The Adolescent-Responsive Contraceptive Services HIPS enhancement is pivotal for us to shift from a youth-friendly, separate space model to a holistic, respectful care model, which is more akin to a systems approach. The Momentum Country and Global Leadership designed tool we are discussing today builds on the HIP enhancement, both of which were designed utilizing the WHO's 6 evidence-based building blocks of essential elements for a robust health system. These building blocks include data, services, access, workforce, financing, and ensuring adolescents are allowed a voice in leadership or governance. What was not included in the original WHO building blocks that has been added for today's tool is community engagement, an essential piece to increasing adolescent health and health outcomes, especially in sexual and reproductive health. The Momentum tool is also aligned with the WHO's Global Accelerated Action for the Health of Adolescents, or AHA, guidance, which emphasizes the need to have adolescent responsive health systems and to include adolescents in the creation of the health system. To achieve universal health coverage, health systems need to normalize the attention to adolescent-specific needs in all aspects of their work. This includes adequate financing and financial risk protection, laws and policies, building an adolescent competent health workforce, ensuring quality health services that are specific to adolescent needs, and ensuring that adolescents are fully visible in all data that is collected. A health system consists of people, institutions, resources, and activities whose primary purpose is to promote, restore, and maintain health. Due to USAID's dedication to supporting health system strengthening, the Bureau for Global Health has a vision for Health System Strengthening 2030. This vision describes the aims of health system strengthening to achieve equity, quality, and resource optimization, which affords every individual a fair opportunity to attain their highest level of health is responsive to individual and population needs, and ensures that health systems adopt sustainable approaches to mobilize. When these aims are achieved, health systems provide quality, accessible, and people-centered care for all, including those who are marginalized or in a vulnerable position. The Adolescent and Gender Responsive Health Systems tool we'll discuss today is meant to support young people, health system actors, and other relevant stakeholders to come together in order to identify strengths and gaps, as well as plan together for a more robust and inclusive health system for adolescents. I thank you again for being here today, for your engagement with this tool in your own settings, and for your leadership in ensuring that nothing happens for youth without their voices and input. Now, Callie, back to you.
Thank you so much, Corey. That was wonderful. And we really appreciate how you were able to situate this kind of shift towards a responsive systems approach and health system strengthening within the global landscape. Thank you so much. I'm going to pick up now where Corey left off and give a bit of a more in-depth overview on this responsive systems approach and what it is. And then we'll get into hearing from our colleagues across various countries about how they've been implementing this approach. So next slide. And then the next one. So I'm going to go kind of quickly through a few of these background slides, because if you're on this call, you certainly know and you probably feel strongly about the fact that adolescents experience disproportionately poor health outcomes compared to older women. And that the reason that they experience those health outcomes are, or those disproportionately poor health outcomes, are multiple. Next slide. One of the is that and one of the reasons they experience those poor health outcomes is that because they face unique barriers to accessing and using high quality health services. Those barriers can be visualized through a socio-ecological framework, as I have on the slide, or in many other ways. And they include barriers at the systems level, social, and individual level. Next slide. Historically, as certainly most of you on this call know, adolescent-friendly services was developed as a response to address many of those barriers that adolescents seek or face in seeking care, especially at that service delivery and systems level. Adolescent-friendly services has been around for 30 plus years. There is a huge amount of country ownership in this approach. There's a wealth of global resources, guidelines, and evidence supporting adolescent-friendly services. And in fact, we know from the evidence that when implemented in line with global standards, adolescent-friendly services can indeed increase access to and use of quality health services by adolescents and young people. But you also likely know, if you're on this call, and you've probably been implementing adolescent-friendly services for quite some time, that they can often be implemented through externally funded projects, which tend to develop separate spaces or corners just for adolescents and youth. And oftentimes those separate spaces or corners only offer a particular kind of service. So just contraceptive services or just HIV services. And while those separate spaces or corners can certainly, as I said, be effective, we have also seen time and time again that they've been difficult to scale and sustain. So I'm sure many of you have gone to a facility, either as a young person yourself or as a professional, and sought out a youth-friendly or adolescent-friendly space, only to find that the space that used to be designated for adolescents and youth was used as storage, gathering dust with boxes, or being repurposed for other more urgent priorities that the health system or other partners had, or simply closed because the provider who was trained in adolescent-friendly services has shifted to another facility. And we see that, unfortunately, time and time again. And so the field of adolescent health, which, as Corey has said, includes folks across the board from USAID, WHO, to many of you, have started to say, okay, we care about serving adolescents with and for adolescents, and we can see that adolescent-friendly services has been challenging to scale and sustain. So what can we do differently? How can we learn and evolve? how can we take what we know works for adolescents, so the principles and tenets of adolescent friendly services, and embed that into a broader health system so the entire health system is responding to and meeting the needs of adolescents, who are, after all, in many places, a quarter of their population. How do we take elements of adolescent friendly services and put them within the broader health system and make sure that adolescents are part and parcel of a health system strengthening approach and a UHC agenda? And as we've talked about doing that, we've shifted our terminology and we've called this an adolescent responsive health systems approach. And as Corey mentioned, the update to the high impact practice enhancement on adolescent responsive contraceptive services in 2020, which was, as Corey said, endorsed by a wide range of global actors, defined adolescent responsive health systems as you see on the screen. It refers to making existing health services responsive to the needs and preferences of adolescents by incorporating those evidence-based elements, what we already know works, into the broader health system. And importantly, this signals an evolution from traditional standalone adolescent friendly services towards this systems approach that has implications on policies, procedures, and programs across the entire health system. Next slide. So, what does this actually look like in practice? And as Corey said, one way that we use to describe and define the adolescent responsive health systems approach is through the lens of the WHO building blocks. And Corey showed those on her screen. I'll repeat them on the next slide here. The idea being, how can we look at each of the building blocks and make sure that they are meeting the needs of adolescents across the health system? Next slide. On the next couple of slides, I'll just give one or two examples of how each building block can meet the needs of the health system, or sorry, can meet the needs of adolescents. And then we'll get into how we can do this practically. So next slide. Under leadership and governance, a responsive health system has policy standards and guidelines that uphold adolescents' rights to health care and are implemented. And there are mechanisms in place at all levels of the health system, facility, district, province, national, for adolescents to hold their health system accountable using social accountability and other mechanisms. In a responsive health system, financing mechanisms address the needs of adolescent health. For example, adolescents are included and covered in insurance schemes. Adolescent care is included in performance-based and demand-side financing. Next. Importantly, many of us have been working on the service delivery building block for decades. Adolescent-friendly services are the great way of enhanced strengthening the service delivery building block. But we have to go beyond one room and one type of service to ensure that adolescents have an integrated package of care, so all health services they need, and that care is delivered through multiple different entry points, not just one room or corner, but multiple facility entry points, school-based services, and community-level services. Similarly, we've been working on human resources for health in the adolescent health space, again, for decades. We've trained providers on adolescent-friendly services, and that's important and really critical. But we have to go beyond that to ensure that adolescent health and gender considerations are in pre-service education, in-service training, which of course we've done, and the supervision, mentorship, and quality improvement processes, which is where sometimes adolescents get left out. Next slide. Health information, as Corey said, age and sex disaggregate data are critical to collect and use. And for commodities, making sure they're available without restrictions by age or any other characteristic. Next. And lastly, this community element, which, as we've noted, was not part of the original building blocks, but is acknowledged to be a critical element. And the health system has a couple of roles to play in the community. First of all, there's the community health system, so service delivery at community level, health promotion, community accountability, and community level data. And all of that must respond to the needs of adolescents. In addition, the health system can promote health and create linkages and coordination with other actors who are working on those critical social determinants of health and behavior change with adolescents. And the health system can partner with the education sector on critical services like school-based services and comprehensive sexuality education. Okay, so you might be thinking, great, I got it. We are taking what we know about adolescent friendly services, we're taking those elements that are critical, and we're going beyond a room or a corner in a facility to really make sure the whole health system meets the needs of adolescents and that each element of the health system is considering those needs and addressing the gendered barriers to care that adolescents face. And you've heard that this has been kind of widely supported and endorsed by WHO, USAID, and many other key actors. But you might be asking, okay, but how do we actually do that? Because we've been doing adolescent friendly services for so long, we all know what to do. We know how to assess a facility and train the providers and generate demand. But how do we take this systems approach in actuality? And the first thing I want to say is that it can happen. There's actually several great examples of countries that have, over the last decade or so, moved in an adolescent responsive health system direction. Ethiopia is one, Moldova, Chile, Thailand. We've had previous sessions and working groups on these country experiences, and we're happy to share further resources about those countries. But over time, they've embedded adolescents in their policies, in their service delivery, in their pre-service education, in their data collection, in their accountability mechanisms, and in their partnerships. But for those countries or subnational geographies, districts, provinces, who maybe haven't quite taken up the systems approach yet, where do you start? And for those of us who work in youth led organizations or nonprofits supporting countries to adopt systems approaches, where do we start? And we had that same question at Momentum Country and Global Leadership. And that's what led us to develop the Adolescent and Responsive Health Systems tool, which we call Is Your Health System Adolescent and Gender Responsive, a participatory tool for analysis and action planning. And this tool can be used to help you get started. And I'm going to go on the next slide. The tool can be used by any of you on the call, as well as ministries of health, civil society partners, and adolescents themselves to assess whether and how a particular part of the health system, whether that be the national health system, the district, a province, responds to the needs and rights of adolescents, and how the system acknowledges and addresses the gendered barriers of care that adolescents face, and then use that analysis to create an action plan to address the gaps. So the tool can be used to assess and identify national or inform national and subnational plans and budgets and policies. It can be used to inform the design of programs and interventions, and it can be used to measure progress over time. Because one of the tricky things with responsive systems is it's hard to count. Much easier to count providers trained or adolescent friendly rooms. But if we have a tool like the one we've developed, we could actually measure progress in how the system responds to adolescents over time. I want to make one thing really clear. This is not a facility assessment tool. We've all used, and there are many adolescent friendly facility assessment tools out there that are excellent. Those are used to look at a particular facility and say, is this facility delivering quality services to adolescents? A very important tool. There are many of them. This is not one of them. This looks at the system. How are the different health system elements really meeting the needs of adolescents and addressing gendered barriers to care? It can be used to complement a facility assessment, or it can be used instead of a facility assessment if you're more focused on strengthening the system. Next slide. So the tool is broken up into different building blocks, as we've been describing. There's one building block for each of the health system strengthening building blocks and the community. And within each building block, there's criteria that colleagues and partners and stakeholders can look at to assess whether and how the system meets the needs of adolescents. And there's a benchmark to score 0, 1, 2, or 3 for each of those criteria. Based on the scores, which come from both adolescents and health system actors, action plans are developed and priorities for system strengthening are identified. Next slide. So now we're here to learn together a bit about more what this actually looks like. I'm really thrilled to introduce our next speaker, who is Kimani Karuga, who's a health system strengthening expert and a consultant at Options Consultancy Services, who's been working with Momentum Country and Global Leadership on strengthening adolescent and gender responsive health systems in Kenya. Kimani was actually, I think, the first person to ever facilitate use of this tool and has been partnering with Momentum Country and Global Leadership over the last several years to both use the tool and then document and understand how the actions are being taken in response to the needs of identified at the county level in Kenya. So over to you, Kimani, and thank you so much for being here.
Thank you so much, Kari, and indeed a pleasure for me to be here and to be talking about this fantastic tool. I have run quite a lot applying it in Kenya, and I'll be sharing some of the insights and some of the learnings we have gathered applying this tool. So this tool was applied in Kenya, really overlaying it on a USAID funded project. At a sub-county level, at a sub-national level. Those are two counties, Samburu and Turkana counties in Kenya, where the Mawiri project was being implemented. So be describing how we applied the tool to support those two counties to really understand how well their county health systems were responding to the needs of adolescents and to be able to start setting up a process of improving or strengthening their systems. And the first step, which is in the next slide, we started by really trying to gather insights from adolescents and young people themselves. As Corey said, this whole process has to start with really bringing on board the voices and inputs of young people and adolescents specifically. And how we did this was first, we identified and recruited representatives of adolescents and young people. And deliberately, we chose those that held leadership positions so that they can speak on behalf of the rest. And therefore, they're speaking on behalf, in their, I would say, professional capacity rather than individual views. And the whole idea was to ensure that we are getting as broad-based perspective as possible. We had a mix of age groups, 15 to 18, 19 to 24, who are the young people. We had both male and female. We had in and out of school adolescents. And again, the whole idea was to ensure that we are getting as diverse a view as possible of how they experienced the health system. We facilitated focus group discussions with those adolescents and young people, organizing sessions of roughly 90 minutes each, and these were groups that were organized in males and females, young and adolescents separately with the same sex facilitator. Idea being to ensure that they open up as much as possible to give their views, perspective about how well they were getting served. We used the tool that Kari just described, although there were certain features that we eliminated because they weren't quite relevant or feasible to get information from adolescents, especially those that were more policy oriented. But we used the tool to be able to facilitate a discussion with this cohort, asking them to describe the situation against each of the building blocks and each of the features. And after facilitating a discussion, inviting them to be able to rate how well that feature performed against the four levels that you saw, 0, 1, 2, up to 3. And that kind of a process enabled us to really compile perspectives from the adolescent young people, which we presented in the next workshop, which was the workshop where we brought together the provider side. Next slide. So the next workshop was with the health system actors. Basically, you would argue these are the provider side. These are the managers. These are the service providers. These are organizations working in the health sector. And therefore, these are the people who are duty-bound to meet the needs of adolescent and young people. And we had a 2 days workshop with them, both representing state and non-state actors in the health sector. And we also invited to this discussion youth and adolescent representatives, more or less a subset of the ones that had taken part in the first workshop. And in this workshop, we facilitated small group works, about 10 people per group, And we really focused on each building block and each feature independently, really asking ourselves how the situation was at that moment, where it was performing well, gaps that were existing, and all that. And through that kind of a discussion, we were able to elicit, very reflective discussions, and through that kind of a discussion, build consensus on what the group agreed on as a state of that feature and that building block. And through that process, we then were able to score or put it, on a scale of 0 to 3 for each of the features. And we also try to use additional information, for instance, information from the health management information system to really validate and triangulate the information that was being shared. So really important to stress is the fact that it was a consensus building process, really a lot of agreeing, disagreeing, and eventually arriving at a state where the group decides that we think the health system is on 1 or 2 or 3, and the reasons thereof. So the next point was on now using those scores to really decide on what are the priority gaps. Next slide. So which was prioritizing and those gaps and developing action plans. Very important because the whole process of assessing the system was to enable them to then decide what actions need to be taken. And again, through group works and really a process of in-depth reflection, discussion from multiple stakeholders' perspective, we were able then to come up with actions that were based on the scores that had been allocated. And to help the process of identifying what is a priority, we used a visual representation or a dashboard that really aggregated the scores for each of the building blocks based on what had been allocated to each of the features. And that is the process of priority setting, because as you'd imagine, the tool, we are talking about 7 building blocks, then each of them has a couple of features. Then, the elements are quite many. Therefore, there has to be really a process of deciding what's a priority, what do we want to focus on over the initial, for instance, 6 months or 1 year. And based on that, then they would draft an action plan, and that would be given to the county leadership or the government department that is responsible, the health department in this case, to be the custodian of the action plan, leading the process of implementing it, including sharing it with the relevant stakeholders like the other departments, because for some of the actions, for instance, related to other line ministries like Department of Education, maybe Department of Water or Agriculture and such. So sharing it across departmental, departments, government departments, and also reaching out to partners that were implementing various projects to be able to create ownership of some of the actions that were agreed. Next. Here is just a visual presentation of how the assessment results were presented. After they scored the various features, this dashboard really represents or helped them to prioritize. As you can see on the spider diagram, you can actually see which of the building blocks scored very poorly. For instance, the health workforce there at 22%. And therefore, you're going to be able to work back to the features to identify what areas or what are the gaps in the health workforce that relates to this low performance. And this helped them to really identify which of the features or which of the building blocks they would want to prioritize or start with. Next. I'll give you an idea of some of the key gaps that were identified through this kind of a process. The first one, and this relates to the building blocks on governance, leadership and governance. They identified that there was very limited adolescent participation in policy making, planning for service, or even in accountability mechanisms. There was also realization that there was very poor translation of policies and guidelines into quality services, and that was partly due to poor dissemination of these policy documents and very low awareness among users and providers. really, or sometimes the lack of requisite resources to be able to implement some of the guidelines. Then there was also health services for adolescent and young people being very highly fragmented, very poorly coordinated, and of very suboptimal quality. Routine supervision and quality improvement processes did not adequately embed adolescent and gender considerations. That was another gap that was highlighted. Then there was also gaps in data collection and use of age disaggregated data in the HMIS system. And particularly, there was the issue of privacy was highlighted. Confidentiality, data confidentiality was highlighted by adolescents themselves. Then the other key finding was about providers of services, where most providers and managers had really inadequate adolescent competencies. Pre and in-service training, supportive supervision did not emphasize competencies around adolescent health. And adolescents also noted that some providers were very judgmental or exerted their personal perceptions, religious and cultural orientation during service delivery. There are also gaps that were noted in terms of community-based interventions, because most of those were donor-funded and were very silo and vertical in nature, intended to really focus on maternal, newborn activities, and did not really have space for adolescent, service delivery. Then the other element that was also highlighted was the poor linkages between health, nutrition, and other programs and interventions that related to the social determinants, for instance, livelihoods and economic developments. Next. And therefore, those are just highlights of some of the gaps that were identified. Now, I'll also highlight to you some of the actions that were prioritized by these two counties. The first there was about leadership and governance, really focused on trying to increase meaningful adolescent participation in policies, in planning, and in particular, even in social accountability mechanisms. And they agreed on very tangible actions that were needed. For instance, ensuring that health facility committees would have a youth representative or an adolescent representative, ensuring that during public participation forums, the views of adolescent and young people would be given specific attention. Then the action agreed upon was to embed adolescent and gender consideration in all routine support, supervision, and quality improvement processes. And this particularly was something that they thought was low-hanging, because there was already a tool, support supervision tool, that all that needed was to include elements of adolescent and gender responsiveness. In terms of community level, community side of this, they agreed to integrate adolescent health and nutrition into community outreaches, especially those that were already happening, and therefore, in terms of the additional resources required, that was minimal. On human resources, it was agreed that stakeholders would really focus on improving provider competencies, including providing in-service training, on-job mentorship, and that already was some of the actions that I am aware the Nawiri program prioritized. On health information, priority was given to enhancing privacy and ensuring that gender disaggregated data was not only available, but was routinely reviewed, analyzed, and used to make decisions. On health products and technologies, there was deliberate action to look at the essential commodity, particularly those that relate to adolescent health, that needed to be prioritized. Now, I'll share a few reflections as I conclude on how use of the tool, or what we really learned on use of the tool. The first point there is about, whether it was found to be useful by the stakeholders in these two subnational counties. And as you can see, majority of the participants, really found the process helpful, and majority said they would really recommend it to others. And two, the fact that this was really a consultative process that started by gathering the views of adolescents and leaded to aggregating this with the available data. It really helped to draw the attention on the issues of adolescents, which were often relegated to the periphery. So it really helped to bring back to the agenda the whole issue of adolescent health and also nutrition and other related sectors. The use of the WHO building blocks as the anchor, as a framing tool, as a framework was really helpful because it helped us to look at the various, have a systems-wide view as opposed to very side of the look that would relate if we were to do this based on a project approach. Then a very important point there is the fact that the whole assessment really started a shift of thinking from what was there before, where the primary strategy was trying to establish adolescent youth-friendly corners in health facilities. In fact, in both counties, there were quite some investments that had happened or already happening, setting up some youth corners. And they were, in almost all the cases, they were not fully functional because of challenges such as lack of, shortage of human resources. And therefore, this shifted that thinking, and the planning now started to look at more of embedding adolescent responsiveness across the health system elements. I think that kind of sums up the reflections and the lessons that we gathered from Kenya. And I would like to transition this to also here from Zambia and also Sierra Leone. So we will hear, I'll be inviting some two colleagues to join me. The first one will be Najma Bawa. Najma is a Ghanaian American public health professional with a background spanning 8 years managing and implementing health system strengthening and community health programming in Sierra Leone, Kenya, and the Gambia. She's currently serving as a project director for USAID MCGL program in Sierra Leone. So welcome, Najma. You can put on your video and microphone. Then the second person will be Ruth Ritaba, who is a gender and adolescent health expert with over 5 years of experience working on adolescent health. She's currently serving as a youth and gender specialist for Coparos Zambia on USAID MCGL project and leads all adolescent health and gender high impact intervention in 2 provinces in Zambia. So welcome on board, Ruth. Okay, so let me start with Ruth. So Ruth, could you, having had the process and the learnings from Kenya, could you describe any similarities and differences in how you and Coparos facilitated the assessment in Zambia context? Do we have Ruth?
I think she had some slight audio issues, Kamani, but she should be able to unmute herself now.
Good afternoon, good morning, everyone.
Good morning, Ruth. So welcome.
Thank you.
The question is, if I may repeat, is having had the process in Kenya, could you describe any similarities or differences in how you and Coparos facilitated the assessment in Zambia?
All right. Thank you so much, Kimani. My name is Ruth Litaba. I'm from Coparos, as earlier introduced. So Coparos, a youth-led organization, carried out an assessment in 2 provinces, which is Central Province as well as Northern Province. So we used the same tool that Kimani and team used. And I must say it was a very good process for us, being the first time using the tool. And from how the assessment went, we had 2 groups of people that we targeted, the adolescents themselves, as well as the stakeholders who comprised of the healthcare providers, the neighborhood health committees, as well as the district management teams. So for the adolescents, we had 2 groups, the males and the females, and we put them in one group. So that made it easier for them to bring out issues that affected them with regards to adolescent health services. For the stakeholders, we also had both males and females. And it was also easier for them to bring out issues based on that. So we had a total of 30 adolescents from one district and 30 stakeholders from the other district. So in total, we had 60 participants per district. So how the assessment went, Copperos being the lead partner on adolescent health on Momentum, we are the ones that did the assessment, and three young people from Copperos led the whole process, and myself inclusive, as well as one male. And in Northern Province, we had one young person and one technical lead who is on the project. So we led the whole process. We started with the adolescents on the first 2 days. We shared what the assessment tool looked like while we were conducting the assessment, and we created an enabling environment for them to just share what their views are, especially with regards to how adolescent health, how the health system is responding to adolescents' needs. So it was an easy process for them because we didn't have anyone from district health office or from the health facilities. So it was an open and safe space for them. We ran them through all the building blocks and all the features. And it was interesting to see how interested adolescents are in issues that affect them. So they brought out issues such as them not being prioritized when it comes to designing of their own programs. So they also brought out issues of them not being part of the social accountability mechanism processes, and also them them only being considered for few activities such as outreach activities are not being part of the whole planning process. And they also brought out issues such as them not being part of the key decision-making spaces at facility level, community level, and even at district level. So action plans were also developed. And I must say that the adolescent and gender responsive systems has also been prioritized by the Ministry of Health, and it is highlighted in the Adolescent Health Strategic Plan. So I think we are in a good place. We have a policy backing, and yeah, based on all those results or findings from the assessment, we are able to prioritize and support the ministry into implementation of the responsive system. So yeah, that's what happened.
Thank you, Ruth. And now we turn to Najma. Najma, what were the main successes and challenges you encountered when conducting the assessment in Sierra Leone, and how did you address the issues you faced?
Great, thank you so much for that question, and it's an honor to be here with all of you. So yeah, similar to Zambia and in Kenya, we also implemented the assessment through a consultant that we worked very closely. And one of the things that I want to highlight in terms of the successes is that we had a really rich cross-section of stakeholders that attended the workshop. We had teachers, police officers, traditional religious leaders, the district health management teams, and they all were able to sit down together and reflect, looking at the various building blocks to see, how is our health system responding to the needs of adolescents and youth. And so it was an opportunity for them to have rich conversations around what has been working and what hasn't been working, and then to develop these action plans to try and address those gaps. Some of the challenges that I wouldn't say per se challenges, but things that we had to put in place in terms of engaging adolescents and holding these focus group discussions with 15 to 19-year-olds is that we had to ensure that we had consent forms from all of the parents of the adolescents that we engaged. So, and then we had to also conduct a risk assessment, looking at the venue, make sure it was well ventilated, making sure that there were separate bathrooms for both the adolescents. In addition to that, ensuring that we had movement plans assessments in place for and understanding that, you know, how the adolescents were coming from their various communities to the township. And so these were various measures that we had to ensure that we had put in place prior to, you know, as part of the planning of holding those focus group discussions with adolescents and youth. And one thing that I wanted to add to that is that we also had similar to what Ruth just said. We had two groups, one adolescent girls that comprised of adolescent girls, and then one for adolescent males. And we had two facilitators, one male, one female, that was able to administer the assessment. Thank you. Over.
Perfect. Thank you, Najma. And coming back to you, Ruth, Copper Rose is a youth-led organization. Could you share a bit about the experience facilitating the assessment as a youth-led organization and how it may have differed? Are there any unique challenges or considerations that you faced?
Thank you, Kimani. So, like you have rightly put it, Copper Rose is indeed a youth-led and youth-focused organization. So, in terms of sharing a bit about the experience of facilitating the assessment, I must say, us being a young population, or us being a young or youthful organization, the facilitators ourselves were young, and it was easier for us to relate with the adolescents themselves. So we ensured that we had adolescents understand that whatever issues they are facing are also affecting us. And we created that enabling environment for them to feel free and be able to air out or share what their views are with regards to adolescent health. So as a youth-led organization on Momentum, we are quite honored and happy to lead the adolescent health work, especially the responsive system implementation. And I must say that when it came to us speaking with the stakeholders, as much as we looked younger, we also brought forward the issues that the adolescents had shared with us the first 2 days. So the last 3 days, when we met the stakeholders, we ensured that we carried all those issues that adolescents brought to us, and based also on our own experiences, we ensured that we directed the conversation in such a way that the stakeholders are able to respond to the needs of adolescents. And I must say that when we were developing the action plans with them, they agreed with us and they agreed with the adolescents, which makes it easier for us to be able to own the action plans that we developed, or rather what the adolescents developed, and also having the districts own those action plans that they came up with. And I must say that we ensured that we advocated for inclusion of those high impact interventions in the district plans that followed after that particular activity. So being a youth-led organization created a space for us to engage meaningfully with the adolescents at community level, as well as during the assessment, as well as the stakeholders that came through.
Thank you, Ruth. So, the whole essence of this tool and the process is to ensure that we are coming up with actions and implementing actions that bring adolescents back to the fold. And now, Najma, maybe you can share with us some of the key actions that have happened after you conducted the assessment, and how those actions have really accelerated the implementation of adolescent responsive health systems in Sierra Leone.
Thank you. So following the workshop that we held, and in conducting the assessment and looking at the gaps identified, we worked very closely with the district health management team to develop some key interventions that we could implement through our local partners and in our project. So looking at the various building blocks under like service delivery through our local partner, Sierra Leone Midwives Association, we've been working very closely at the facility level to build the capacity of healthcare workers to provide, large services at that level, and really including respectful care to ensure that when adolescents are seeking services, it's done in a dignified way, and privacy and confidentiality are issues are addressed. In addition to that, we've integrated quality improvement at the facility level. So we've used a tool that was administered by health providers to really understand adolescents and youth perspective on the care they were receiving. And through that data, we're hoping to work with each of the facilities that we work in to develop adolescent quality improvement focused aims to look at how the health providers can improve quality of care at that level using the resources that they have. And this has been really an interactive opportunity for the adolescents and the adolescent focal point at the facility to engage in conversations to understand what those challenges are with adolescents. We rolled out adolescent-friendly service training with health providers. And one of the unique things that we did was that we actually had adolescents and youth come and engage in a dialogue around their challenges, when they're seeking care. And they actually utilize a quality improvement tool called the fishbone analysis to really unpack what those challenges are. And again, feeding back into their ability to really design interventions and address some of those challenges that they identified. Through another health local partner that we work with, Health Alert, they are a coalition of civil society organizations, and they have a number of adolescent and youth organizations within their coalition. And through, we recently were able to train them in smart advocacy. So under the umbrella of leadership and governance, giving them the tools to hold district and national stakeholders accountable to the commitments they've made through national level, strategic documents around funding, funding for adolescents and youth, family planning, et cetera. And so they've held a number of district level engagements with district officials for them to be committed to really addressing the concerns in adolescents at community, facility, and district level. And then also in the recent year, we've worked on developing the costed implementation plan for family planning, and which is feeding into the family planning 2030 commitments for Sierra Leone. And as part of those engagements, we made sure that adolescents and youth voices were amplified. So we held focus group discussions with them, and a lot of their concerns were incorporated, and even solutions were incorporated into these national strategic documents. And as part of Health Alert's kind of task for the next couple of years is to use a tool called the Motion Tracker to track these commitments at all levels to ensure that the government is actually adhering to the commitments they've made to address the health system as to how it responds to adolescents' needs. And then lastly, that I would want to highlight is through another partner that we're working with, we're also looking at stock out. That is a major concern here in Sierra Leone, and adolescents, when they're seeking services, really are challenged and are really deterred from going to the health facility because of the frequent stock out of commodities. And so through working with the Ministry of Health, we're supporting a pilot to deploy a digitized stock management tool to really look and to improve data visibility of commodities at the last mile, to really support the ministry to do better forecasting, to hopefully address these bottlenecks around commodities that are needed by adolescents and youth. And then lastly, something that I do want to share is that last year we were able to hold a national adolescent and youth summit, again, amplifying the voice of adolescents and youth to ensure that they are part of the, not only just sharing the challenges, but also part of the solution making in front of these national and district stakeholders. And so we had a hackathon which looked at a number of four different challenges around improving access to SRH information, using technology to improve uptake of family planning, et cetera. And we had these adolescents from across the entire country design their own solutions, and they came up with apps and leveraging various modes of transportation to disseminate key information. And it was really amazing to really to see how if you put the power of the power or the if you bring adolescents and youth to the table, how they can really bring light to how the health system can address and support their needs. So I'll end there. Thank you.
Excellent, thank you. So let's conclude, and maybe you both, this goes to both of you. Do you have any piece of advice that you can give to stakeholders out there who would want to shift using this health, adolescent responsive health systems approach, as opposed to what has been there, the corners as were described earlier? Ruth?
Yeah, definitely. So for organizations that would want to go a responsive systems way, my advice would be that adolescents should be involved. Adolescents should be involved meaningfully and engaged in all aspects of the system. So I'll talk of why adolescents should be involved. So when we want to involve adolescents in the process, we want to bring out a youth centered perspective. Adolescents know what their needs are, and they know what really affects them. So if we involve them in the planning process, in the implementation process, and in all other processes, it's easier for them to bring out issues that are of high impact. We have quite a lot of challenges that we face. For example, here in Zambia, we have high teen pregnancies, we have STIs among adolescents, we have HIV new infections, and all those issues that affect adolescents, mental health, drug abuse, you name them all. But if we bring them on board, they're able to tell us what their challenges are, what their perspectives are, and how we could better program adolescent health for them. And also the other issue is that if we involve adolescents in the process, it's easier for them to own and they will be empowered. So there'll be that sense of ownership amongst them, and they'll also feel empowered. So at facility level, if we say we want to do activities, high impact interventions for adolescents, they will know that this is our program and we're involved in the planning process of this activity. So they'll come through, they'll be empowered in such a way that the information and the knowledge given to them will help them and will help those other adolescents that are in the communities in order to do what? To curb some of these challenges that adolescents face. And other than that, we get diverse perspectives. We have so many different types of adolescents. We have the young adolescents, we have the old ones, we have the older, the late adolescents, as well as the young people themselves. And we also have adolescents living with disabilities, adolescents that are living with HIV and so many adolescents. And so if we engage them, it's easier to develop programs based on what their needs are. And it's easier to implement and be able to speak to them because they were involved in the first place. And if we talk of service delivery, leadership and governance, adolescents should be in charge of, should be part of the leadership should be part of the decision-making spaces that discuss their issues. And I'll talk of maybe, for example, the technical working group meetings that happen at district level, where adolescents when their issues are being discussed. But if we bring them on board, they will be able to speak through, they will be able to bring a youthful and an adolescent voice to that space. When we talk of the neighborhood health committees at community level, adolescents will be able to influence some of the decisions made for them by the old people, or rather by the big people. And you'll find that some of the interventions implemented by the ministry will also speak to adolescents in a more meaningful and positive way. And the last thing that I would like to talk of is program effectiveness. When we involve adolescents in the process, in adolescent health responsive process, we tend to have our programs will be effective. So many are the times when some of our programs don't really yield anything, because at the planning process, we left them out. And even when implementing, we still left them out. But then those are our target groups. So how then do we plan for an activity that doesn't involve them? How do we go in the community and implement an activity and do not involve them? So for us, it's some sort of, we want adolescents to be at the center. We want the young people to be at the center of all our activities. That way they will feel empowered, they'll be part and parcel of the activities being planned for, and they will carry forward the mandate to improve adolescent health. Thank you.
Thank you so much, Ruth, and I think that's a powerful way to end. I see our time is over, and allow me to then invite Meroji, who will facilitate some time for the audience. Thank you.
Thank you, Kimani, Ruth, and Najma. And hello, everyone. My name is Meroji Sabani. I'm an adolescent and youth advisor on the Momentum Country and Global Leadership Project. I'll be facilitating the next section of the workshop and want to now open it up for questions and discussion. If you have a question, please use the raise a hand feature by clicking on the reaction button and selecting the raise hand option at the bottom of your screen. Will give you the ability to unmute yourself to ask your question. I see that we have one Kumbu. Please go ahead with your question.
Okay, thank you so much. I think for me, it's just to commend the two speakers. I think they have highly and well elaborated their responses, especially emphasizing on the need for including adolescents and young people in the implementation of our various activities and interventions that we are conducting. I think I cannot overemphasize the powerful conclusion that Ruth has given on some of these interventions succeeding. They require that at the beginning, at the planning stage, the young people are involved, at the implementation and at the conclusion level, because these young people are the ones that are going to take up most of these spaces, and they speak to the real issues which the older people may not be able to understand. So I think for me, lastly, I want to say, job well done for the presentations and for putting this meeting together. It has been informative for me. Thank you.
Thank you so much. Bethlehem, please go ahead with your question.
Thank you very much. I hope I'm heard. First of all, thank you very much for putting this great tool available, and also for the great presentations. Going through briefly around the tool and hearing the presentations, I just have some questions or maybe some remarks that may enrich the tool further if there's any chance. The first remark that I have is around, how adolescence, the age of adolescence is defined. Of course, not only the age, but also the other social factors. For example, those married and unmarried, those in school and out of school, or maybe in the urban and rural areas. So are those factors included to define adolescence in this tool, or can we use a tool to assess the situation of health systems that involve all these characteristics of adolescence? And the other question I have is going through the main milestones of the tools or the blocks. I was wondering if a definition is provided for the questions, because not everyone understands the questions right away. So some people may need definitions to really understanding to utilize the tool. So was there any definition provided? I'm asking this because some of the question might be a little bit vague. If, for instance, people in the sector may be using it. For instance, adolescents participation. Participation can be understood differently by different people. So, it should be clearly defined and presented to those who are using the tool. So, was there any chance to do so in the piloting stage? And one more comment or question I have is around the competencies of health providers, and this is an excellent point of inquiry. I was also wondering if the attitudes of health service providers was also included, because it's one thing to have the competency, but also another to have the right attitude to provide health services to adolescents. And we know that there is a gendered biased and stereotype around adolescents in different countries, including Ethiopia, where I'm from. So was there a chance to really look into how health service providers' attitude was a factor to really look into the level of service provisions and its quality? Thank you very much.
Okay, thank you so much, Bethlehem. Maybe Callie, I'll ask you to respond to a few questions that Bethlehem posed, and we'll have to wrap up the Q&A after that.
Thanks, Maroji. I actually think maybe I'll respond in the chat, and we could just take we could take one or two other questions, and then we'll respond to them in the chat box so that we can hear some more feedback from folks. Maybe one or two more, and I'll respond in the chat. But thank you very much for the great question.
Thank you. Lamessa, please go ahead.
Thank you very much. Can you hear me?
Your voice is quite low. If you could please speak up.
Okay, so what about now?
Yes, that's better.
Okay, thank you very much. So it is really interesting to just set for the tool to improve health system responsive to adolescent health needs. That is really impressive, but still, while we need competent providers, how come we make all health professionals actually competent enough to respond to adolescent health services? What we need to maybe discuss about, because still adolescent needs health system responsiveness plus maybe specialty care, having adolescent competent providers also who are responsive to uniqueness or unique special features of adolescents. So if those who already are into it actually share maybe their experiences to actually hold health systems or all providers actually can be responsive to the health needs, and still we need to also invest on competent providers who can make responsive or special needs of adolescents and respond to the adolescent health needs. Thank you very much.
Thank you so much, Lamessa. In the interest of time, we'll end the Q&A here, but please continue to put your questions in the chat box and we will respond to them throughout the rest of the workshop. But thank you all for your comments and questions. Caroline, if you could please pull up the slides. We'll be going into our small breakout activity soon. Before we do so, I wanted to just share a few instructions. All the participants today on the workshop will be randomly assigned to one of 4 breakout groups, which has a unique topic related to the practical application of the adolescent and gender responsive health systems tool. You see the 4 topics on the screen. We'll ask each group to tackle 2 questions in each breakout room. We'll display them on the screen and I will also put them in the chat box. There'll be 10 minutes in each breakout room for brainstorming, facilitation, brainstorming, discussion, and adding contributions on a mural board. Each group will have its own facilitator. So after the 10 minutes are up, a new facilitator will move into your group and they'll discuss a different topic. Please stay in your room. We'll repeat this 2 more times to ensure participants have rotated through all 4 of the topics that are shown on the screen. After that, we'll bring everyone back into plenary and we'll close the workshop. So we'll now be moving into our breakout groups in a few minutes.
Welcome back, everybody. You're being pulled back in. We probably interrupted a few of you mid-sentence. Sorry. It's always the challenge of group work in Zoom is bringing people back together and interrupting those conversations. We're happy to see so many of you still here. Thank you so much for sticking with us for this full workshop. We're going to wrap up now in our last couple of minutes. I want to say that I want to reiterate that we'll definitely share the recordings, the slides. The tool link has been put in the chat box several times. And Caroline, I think we can take off the screen share. The tool link has been put in the chat box several times, but we can re-put it in the chat box. And we will also share out these mural boards so you can see what you and your colleagues thought were relevant for each of the stages of the assessment. I want to thank you all so much for joining us. I want to thank all of our speakers and our USAID colleagues for their support. And I want to reiterate a couple of the key points that we've covered today. So first, we talked about why are we shifting to this adolescent responsive systems approach, and how is it being supported by a number of global and national commitments, WHO guidelines, high impact practices, and donor support. Then we talked about how to get started on a responsive systems assessment, because so often we're used to just assessing the facility, then training providers, and then assessing the facility. How do we look above that and focus at the systems level? And we introduced the Momentum Country and Global Leadership Responsive Systems Assessment Tool as one way to get started. Not the only way, but it's one way. And we hope that you learned a little bit more about how this tool has been used in Kenya, Sierra Leone, Zambia, El Salvador, and the experiences that our colleagues from those contexts shared about how to engage adolescents in assessing and how to foster government ownership over these plans and processes, and specific examples of how to strengthen the system. So for example, embedding adolescent considerations in the QI system, expanding service delivery points to include community-based points, gathering and collecting age disaggregated data and using that to inform systems responses, and most importantly, perhaps ensuring that young people are holding the system accountable through systematic accountability mechanisms. We hope that you will work on this shift towards responsive systems in your context, and we hope you'll reach out to us. We're happy to share the tool, examples, and technical assistance to support you in that journey. I put my email in the chat before. I'll put it in there again as we wrap up, and we hope that you will reach out, use the tool, and share your experiences and give us feedback. Everything is a work in progress, and we're happy to adapt based on your needs and experiences. With that, we will wrap up, and we thank you all for your time and contributions.